Why don't I start by just saying welcome all to the, I think it is our 8th of the series, the 8th or the 9th, 10th of our series on 1619, the legacies of 1619. We welcome Brian Smedley, and we thank you for showing up on a beautiful Friday afternoon when all sorts of activities running around campus. We know that you are the committed of the committed. So let me hand this over to Stephanie, who will start the ball rolling.
Okay. I was actually trying to quickly count up the number. This is probably about the 14th or so of our lectures, somewhere around there. Well, first of all, welcome everybody. Welcome to this penultimate lecture in our 1619 series. As you know, the series commemorates the 400th anniversary of the landing of Africans in British North America and the legacies of the slave system that follow. We've gone from Africa before the start of the transatlantic slave trade through slavery, Jim Crow, civil rights, an array of the legacies of slavery through the 19th, 20th, and thus far in the 21st century. I want to pause here to thank all of you for being here today. I said this earlier, it's a beautiful day outside. It's a Friday afternoon, it's homecoming weekend, and there are lots of other places that you could probably be today. So thank you very much for showing up. Thank you also to the committee members who started this discussion for this program, for this series more than 3 years ago. Thank you, John Brooke and the Center for Historical Research for managing the logistics of this program, and the History Department office staff for carrying out those bureaucratic, financial, and other related obligations. I want to also just extend a really special thanks to those of you who've been showing up since the beginning. Many of you not former committee members, not even members of the History Department. We're really grateful for your commitment, and we celebrate your intellectual curiosity and interest. And we hope that we have both satisfied and added to those interests and curiosities. Thanks to our sponsors, the Department of History, the Department of African and African American Studies, the Center for Historical Research, the Office of Diversity and Inclusion, Ohio Energy Partners, who saved this series when COVID shut down the university and made external support critical to our carrying on. Thanks also to the office staff for all of the ways that they have supported us, from technical concerns to bureaucratic ones. We're really grateful for all of the support we've had. Let me just say to the audience real quickly that when the lecture part of this program concludes, we will have a question and answer session. We ask that you put your question in the chat box, and we will do our very best to get to as many of those questions as we can. That process might involve our having to combine some questions, we'll see, but we're going to do our very best to get to as many as we can. I'm really happy today to continue our discussion in a way that focuses not just on what has happened, we're a history department, that's what we do, but also, in this case, to what is still happening that we can trace back really to the founding of this nation. I doubt that there could be a better moment in time to have a public health expert here to talk with us today. I'm especially happy and grateful that that person is Dr. Brian Smedley. As someone who has spent virtually his entire professional life, probably all of it, I'm trying to be careful here by saying virtually, but probably all of his professional life studying, organizing around, and working to resolve major problems related to health equity. I just cannot imagine a more appropriate person to have here today. Just a little bit of his career trajectory should suggest to you the great treat that we're in for. He's a co-founder of the National Collaboration for Health Equity. He has served as vice president and director of the Joint Center for Political and Economic Studies Health Policy Institute. He's also served as co-chair of the Robert Wood Johnson Foundation Culture of Health Leadership National Program Center. That's a mouthful for me. and as senior program officer at the Institute of Medicine, where he directed major research reports on disparities in public health care and diversity in the profession. His awards are many. Among them are the Congressional Black Caucus's Leadership and Advocacy Award. He won their Health Hero Award twice. The American Public Health Association awarded him their Cornley Award for social activism. He's not just someone who studies problems and talks about them. He's also somebody who does something about them, who works to do things about them. Beginning in 2022, Dr. Smedley will become a member of the inaugural class of the Equity Scholars at the Urban Institute in Washington, D.C., where scholars conduct social and economic policy research. He completed his AB degree at Harvard University in psychology and social relations, and his master's and PhD degrees in clinical psychology at UCLA. And finally, it's just a real treat to turn the floor over to Dr. Brian Smedley, who's going to speak on race, place, and chronic disease, inverting the lens to address the roots of health inequities. The flyer that went out had a slightly different title, but the content that he will cover will be related and connected. He just has a new title, so don't fret if you came to hear something in particular that you expected to be in that presentation. It's probably going to be in this one too. Anyway, I'm going to turn the floor over to him, and maybe we can all do a virtual hand clap.
Thanks so much, Professor Shaw. Thank you, Professor Brooke. I am delighted and honored to be part of this series because I've seen the speakers that you've had associated with this series, really outstanding scholars. I love the fact that you are focused on action, not just scholarship for scholarship's sake. And I'm particularly pleased that the Center for Historical Research is a sponsor. As you'll see from my talk, I believe that history is a critically important discipline. If you want to study and rectify health inequities, you're going to see me attempt to connect a direct line between our history, the kinds of public policies that we have had in this country that have perpetuated racial inequality in ways that get under the skin and literally affect the health and well-being of people of color. So yes, I do have a little bit of a different title, but I promise you this will be about structural racism. I call this presentation Place, Race, and Chronic Disease because I'm going to attempt to connect the relationship between place, where we live, work, study, and play, race, that social construct that we know in the United States as race, and chronic disease. We all know that people of color, particularly African Americans, some in the Latinx population and indigenous populations have higher rates of chronic disease. Why is that? Is it something genetic or biologic? Of course not. We know that race is a social construct. There is no genetic or biologic underpinning behind the concept of race. The concept of race is entirely social. So how do we understand these disparities? Well, the reason why I call this talk Inverting the Lens is because I've given this talk to my friends at the National Institutes of Health, the National Academies of Science, Engineering, and Medicine. And my message is the same, that for too long, our federal government has invested disproportionately vast dollars in bench sciences, biomedical sciences, geneticists, cellular biologists, and others have benefited from the largesse of federal funding to understand racial and ethnic health disparities. I want to suggest that that process of looking through the lens of a microscope has been wrong. It's led us down the wrong path. Rather, we have to invert the lens and study society rather than studying microscopic phenomenon. And so you'll see through this talk that we really need to understand our social and economic policies with respect to race, to understand how in many respects our government has created and perpetuated racial inequality in ways that lead to health inequity. So we're going to invert the lens this afternoon. We're going to take that lens of the microscope and shift it from the slide to society. So I am excited to speak to you about this topic today. Let me just begin by advancing my slide if I can. And I see it's giving me a little trouble. Here we go. Okay. I want to start out by talking about what produces health. Most of us in this country believe that you are healthy if you eat right, if you exercise, if you go to the doctor. Those are clearly important individual health behaviors. But at the societal level, what produces health? I want to suggest that health and well-being are more than a byproduct of what we do as individuals. What we eat, whether we go to the doctor, health is in many respects a production of society, reflecting our policies, practices, and values, as I hope to illustrate in this talk. We also know that health is closely correlated with opportunities for things like educational attainment and economic mobility. In fact, the best predictor of your health status as an individual is your educational attainment. But we know that there are structural barriers for many people of color to attaining their highest possible educational status. We know that economic mobility is important for health. The degree to which you have a high income, wealth, the presence of good schools to help you get to that point, or capital to start a business. All of these are factors that are well outside of the doctor's office that also are associated with health status at the population level. Health is powerfully shaped by the places and spaces where we live, work, study, and play, what we call the social determinants of health. So in fact, health is not produced in the doctor's office, but rather in our communities, our schools, our workplaces, our houses of worship. These are the places that we need to begin to examine, and the social, economic, and political arrangements within those settings that lead to inequality. Health is therefore influenced by a wide range of what we might call non-health policies: housing policy, education policy, transportation policy. Land use is as important, I will submit, as our policies around health insurance coverage, our policies around ensuring that people have a healthy diet. We've got to be looking at these factors outside of the doctor's office to understand how we can create policies that deliberately promote health and well-being for everybody and not just some. Groups that have faced health inequities often face a range of barriers to health and well-being that result from our policy choices. So if I leave you with nothing else today, I hope I leave you with the recognition that the policy choices that we've made in many respects continue to disadvantage people of color with respect to health. Let me start by talking about what is it that we mean when we talk about racism. Now, I recognize that this is a sophisticated audience. You understand racism, you're studying racism, and it's on the one hand gratifying to see so much interest in public conversation about racism, so much discussion about systemic racism. But on the other hand, it's frustrating because it's clear that many in the public sphere don't know what they're talking about when they talk about racism. We continue to think about racism at the level of the average person as an interpersonal phenomenon, as there being a few bad apples who harbor racial animus and express that through their words or their actions. Well, certainly that persists, but we've also got to be focused on how racism operates in our political systems, our institutions, our systems, and that's what I've been focused on in my career. I want to point us to the definition that Dr. Kamara Jones has offered. Dr. Jones is a former president of the American Public Health Association. She herself is an epidemiologist. Many years ago, she argued that racism is a system. So when we talk about systemic racism, that is what we're talking about: a whole system of structuring opportunity and assigning value based on what we look like. We all have common assumptions about skin color, hair texture, and we associate those attributes with what we call race here in the United States. So certainly we look at people, we process what they look like, and we assign a racial category to them automatically and often unconsciously. And so we all understand that race becomes apparent when people present themselves and we make those associations. But Kamara's definition goes further to argue that racism unfairly disadvantages some individuals and communities, specifically people of color in the US context. It unfairly advantages other individuals in the US context, people of European descent, and ultimately undermines the full potential of the whole society through the waste of human resources. A very important point. What Kamara Jones is arguing here is that because we have failed to invest in, for example, youth of color, in high quality education, high quality healthcare, ensuring that these young people can grow up to be as productive as possible, that is a waste of human resources because we fail to see the value of these children and rather subject them to conditions that are harmful for health and human development, reflecting a lack of priority in investing in our young people of color. Now, as I alluded to earlier, racism is not simply an interpersonal phenomenon. It's not simply the fact that we have individuals with negative racial attitudes. Racism is much deeper than that. And in fact, structural and institutional forms of racism, I would argue, are insidious and are deeply complicit in racial and ethnic health inequities. Structural racism results from a system of social structures that produce cumulative, durable, race-based inequalities. What's an example of structural racism? Residential segregation, which in fact, as I'll talk about, is not an accident. Residential segregation was created by government policy and practice, social policies and norms, and violent resistance to integration from white families throughout much of American history, including through today, if you're reading our newspapers. School segregation is also an example of a structural form of racism. We don't need individual racists to help perpetuate and maintain residential segregation and school segregation. They persist as a result of our history, the fact that we set into place policies, practices, laws, and customs that created separate and unequal spaces for people of color relative to white Americans. So I'm going to focus on exactly this issue, segregation in our neighborhoods. And I'm going to illustrate why that creates health inequities. And as Dr. David Williams suggests, is a foundational root cause of racial and ethnic health inequities. Institutional forms of racism result from policies, practices, and procedures of institutions that have a disproportionately negative effect on people of color in their access to and quality of goods, services, and opportunities. There are many examples of institutional forms of racism. None of these forms of institutional racism specifically say you, the institution, should disadvantage people of color. They're almost always neutral on their face with respect to race. But nonetheless, we see these policies and practices playing out in our communities. From a health standpoint, the fact that we have much more aggressive policing in communities of color with things like stop and frisk, the broken windows theory of policing, harassing residents of highly segregated communities of color, that in itself poses health risks to people of color, as you obviously know, due to the high rate of injury and mortality at the hands of police, but also the secondary effects of police-inflicted trauma on entire communities. When people of color, for example, are killed by police unfairly, that doesn't just affect the individual victim or their family, it affects the entire community because of the trauma and fear that is engendered by this form of state-sanctioned terrorism. So policing, heavy, aggressive policing in communities of color is an institutional form of racism that has direct and indirect consequences for the health of people of color. Individually mediated racism, again, obviously, this is what most Americans think about when we talk about racism. They believe it's confined to just a few individuals who are bad apples, individuals with racial bias, treating people from racial minority groups poorly or in a discriminatory manner. And this, again, obviously persists, even among folk who are well-meaning. And I'm going to illustrate how that happens shortly. And then finally, we have internalized forms of racism. And from a health standpoint, from my view, we have had insufficient research to understand the consequences of internalized racism on the health, mental health, and well-being of people of color. Internalized racism refers to the acceptance by marginalized racial populations of the negative societal beliefs and stereotypes that are common throughout our society about people of color, beliefs which can lead to the perception of oneself as worthless and powerless. So my talk this afternoon will focus more on structural and institutional forms of racism, but I just want to make you all aware that when we're talking about racism, we're talking about racism operating at many levels. And I would submit that if we are to be serious about addressing racial and ethnic health inequities and advancing health equity, we have to address racism at each of these levels simultaneously to be able to truly uproot and dismantle the effects of racism on health. Now, the many forms of racism often operate simultaneously in ways that mutually reinforce each other. So, for example, much of the residential segregation in the United States is reliant on both institutional discrimination in the real estate and housing finance market and individual interpersonal discrimination in real estate and housing transactions. How can this possibly be true? Well, sadly, we have research that documents these phenomena. We know, for example, that African-American home mortgage African Americans seeking a home mortgage are less likely to get the same high quality products as white applicants with equivalent financial background scores. And this happens because of many factors, including things like the zip code of the applicant. There are algorithms that unfairly disadvantage people living in highly segregated zip codes because those applicants are often discriminated against without even the color of their skin being seen. We also know that discrimination persists in real estate and housing transactions. How do we know this? For many years, the Department of Housing and Urban Development conducted audit studies where they trained paired testers, one white, one a person of color, giving them equivalent financial backgrounds, fictitious financial backgrounds, and they asked them to seek rental housing, or they asked them to ask a real estate agent to see a home that's on the market for sale. And unfortunately, in between 20 to 30% of those interactions, the paired tester of color receives poorer treatment. They're steered away from more desirable housing. They're not shown desirable rental properties, whereas the white paired tester may follow up a few minutes later and get preferential treatment for that same property. So sadly, discrimination persists at many levels in our housing markets. It's also true that the many forms of racism often operate in ways that mutually reinforce each other. So, for example, at least some of the healthcare quality disparities in the US are due to physician biases. They're either explicit biases or implicit biases. Many of you may have heard about the phenomenon of implicit bias. That's where people come to automatic judgments about people and situations based on factors such as race or other demographic factors without even being consciously aware of it. And it is true that physicians can harbor those implicit biases and explicit biases just as average US citizens can have these kinds of biases. However, if you're a physician working in a safety net institution, a healthcare system characterized by time pressure, resource constraints, and the complexity of problems that patients present, you are more likely to fall back on biases, implicit or explicit, because as a physician, you're trying to fill in missing information, the kind of information you can't gather because of the attributes or characteristics of that health system. So the very health systems where people of color are more likely to be seen are in fact the same kinds of systems that are more likely to activate implicit biases among physicians. In turn, pressures on safety net systems reflect structural issues, such as the fact that we see healthcare as a market commodity here in the United States, and the geographic maldistribution of healthcare resources. It remains true to this day that there is a higher concentration of high quality physicians, hospitals, and clinics in wealthy communities in the United States. And there are a relative lack of those same kinds of healthcare professionals and institutions and systems in high poverty communities. So the best healthcare services are following the money. And of course, that disadvantages people of color at a structural level. So the very fact that we continue to see healthcare as a market commodity means that structurally, we will continue to have a maldistribution of our healthcare resources, with more and better resources being concentrated in wealthier and whiter neighborhoods. Ironically, the very neighborhoods where those services are less needed relative to higher poverty, segregated neighborhoods. I want to focus on the role of residential segregation as a root cause, as I mentioned earlier, of health inequities. Now, of course, we've made progress in desegregating our neighborhoods over many, many years, but the true promise of desegregation has yet to be fully realized. I was born in Detroit in 1963, prior to major civil rights legislation in 1964, 1965, 68, et cetera, with the Fair Housing Act. It was legal to discriminate against people of color. And so we saw very deeply segregated neighborhoods when I was growing up in Detroit. And of course, throughout the 60s and 70s, in many cities around the country, we saw significant white flight from neighborhoods that were previously overwhelmingly white. But as people of color began to purchase homes in previously all-white neighborhoods, in many cities, we saw a vast outmigration of white families to US suburbs seeking less integration. I want to bust some myths here. As I mentioned earlier, many Americans think that racial segregation is simply the result of economic forces, right? People of color have less income, less wealth, so they tend to be concentrated in higher poverty neighborhoods. Well, that is in fact a myth. Yes, the amount of money that you have available for housing does constrain your choices and opportunities, but we have to acknowledge that federal, state, and local governments systematically impose racial residential segregation to begin with, which I want to submit to you is at the root of not only health inequities, but also educational inequities, wealth inequities, and income inequities, because of the ways that residential segregation inequitably distributes opportunity in the United States. But we saw our governments at every level promoting segregation through things like racial zoning, being explicit that people of color could not purchase properties in certain neighborhoods, and homeowners using racially restrictive covenants or religious covenants that prohibited the sale of properties to families other than white and Christian families. We know that many of these governments cited public housing in already poor and low-income communities rather than citing them in mixed-income communities, which further entrenched poverty in highly segregated neighborhoods. Governments also created subsidies for builders to create whites-only suburbs. This was particularly true after World War II. As veterans were returning home from World War II, they could take advantage of opportunities for low-cost home loans. But the only families that were allowed to purchase in newly created suburban subdivisions were white families because of racially restrictive covenants and racial zoning, meaning that Black returning veterans could not take advantage of the same opportunities to purchase high-quality housing at affordable rates. Governments also created tax exemptions for institutions that enforce segregation. And as importantly, they failed to counter violent resistance to integration. Throughout the 30s, 40s, 50s, and 60s, as African Americans began to attempt to integrate, particularly suburban communities that had been overwhelmingly white, they often met violent resistance from neighbors. Governments did little to quell that resistance, resulting again in patterns of segregation that persist to this day. The consequences of segregation remain with us. Many of you are familiar with the concept of redlining. That was simply where the old Federal Home Ownership Loan Corporation assigned levels of risk to different neighborhoods across different communities. And almost every metropolitan area saw the Federal Home Ownership Loan Corporation rating the risk for mortgage insurance across different neighborhoods. Those neighborhoods that were considered to be safe investments were shaded green on these old federal maps. Those that were slightly less desirable, but still safe, according to the federal government for investment, were shaded blue. But those that were deemed risky, in other words, highly segregated neighborhoods that had high concentrations of poverty, were shaded either in yellow or red, the worst designation that the federal government could apply, which meant, in effect, that the government would not back federal home ownership loans or provide home mortgage insurance. That was not simply limited to home mortgages. That very act constrained other forms of investment in those redlined neighborhoods. It constrained business investment. It constrained capital. It prevented families from effectively owning homes so that they could accrue value and be able to pass along that value to their descendants. Did you know that today, 3 out of 4 neighborhoods that were redlined on government maps 80 years ago continue to struggle economically today? 2/3 of neighborhoods deemed hazardous in the 1930s are inhabited by mostly people of color residents. And cities with more of these neighborhoods that were redlined have significantly greater economic inequality today, some 80 years after this practice was employed. On the flip side, 91% of those areas classified as best in the 1930s remain middle to upper income today, and 85% of them are still predominantly white. So the consequence of that policy decision to deliberately disinvest in communities of color remains today. Told you I was going to bring some history in here. It is critically important to understand our history, to understand how we got here, and how to get out of this situation. All right, I want to show you some data that show the depth of residential segregation in several major US cities. What we're looking at here are data compiled by demographers such as Jim Fry, Doug Massey, and others, using a measure called the dissimilarity index. The dissimilarity index is simply the proportion of 2 population groups that would need to move to create complete integration in a defined geographic area. So as you can see from this bar chart, if you look on the far left, this was the dissimilarity index for South Africa in 1991, prior to the dismantling of apartheid in South Africa. As you can see, South Africa at that time had a dissimilarity index of 90, meaning that 90% of Black and white South Africans would need to move to completely integrate that country. And of course, that was the point of apartheid, to keep the races separate. But did you know, as late as 2010, several major US cities were not far behind the level of segregation found in South Africa in 1991. Detroit, my hometown, had a dissimilarity index of 85 in 2010, meaning that 85% of Black and white Detroiters would need to move to create complete integration in the city of Detroit at that time. Milwaukee, Newark, Chicago, New York, all of these cities had dissimilarity indices of 80 or higher, meaning that 4 out of every 5 Black and white residents of those cities would need to move to create complete integration in those cities. I'm still waiting for the 2020 census data so we can update this analysis, but sadly, analyses to date suggest that these numbers are not changing very much. In other words, we will still see many of our major US cities at the level of separation that was characteristic of South Africa during the apartheid era. A remarkable statistic. And another thing that I hope that you will notice here is that many of the cities that we're talking about here are in the Midwest or Northeastern region of the US, not the South. People tend to think that the Southern region is the most segregated in the US, but the most violent resistance to integration in our residential neighborhoods was in the Northeast and Midwest. Those were the cities that either through law, custom, policy, practice, or violence and terrorism found ways to preserve whites-only enclaves in those communities. Why am I emphasizing the role of segregation? Well, we know that segregation tends to concentrate poverty and exclude and isolate communities of color from the mainstream resources needed for success, such as access to good schools, access to capital to start a business. And none of those deficiencies are the fault of individuals who live in those neighborhoods that have suffered from disinvestment. So in this way, segregation restricts socioeconomic opportunity by channeling people of color into neighborhoods with fewer opportunity structures, fewer employment opportunities, smaller returns on real estate, a significant contributor to the so-called wealth gap between whites and people of color. Many of you know that for every dollar of white wealth, African Americans currently have about a nickel of wealth. For every dollar of white wealth, the Latinx population has about 6 cents of wealth. Much of that can be explained by housing and the fact that we have restricted access to purchasing homes in the most desirable neighborhoods for people of color. For white families, that has provided a very convenient way to pass along wealth, because as those homes appreciate in value, they're going to appreciate much faster than, say, an equivalent property in a highly segregated community of color. And in this way, white families have been able to pass along wealth to their children and other descendants going forward. And people of color have not had similar opportunities. There's more, unfortunately, to the role of place in shaping health. We know that African Americans are 5 times less likely than whites to live in a census tract with a supermarket or grocery store, and are more likely to live in neighborhoods with a high percentage of vendors selling unhealthy food, such as fast food outlets, liquor stores, convenience stores, disproportionate tobacco advertising and sales. These are so-called food deserts, places where people cannot access nutritious foods and rather have to rely on a daily basis on products that are often high in sodium, high in fat, high in sugar. And then we wonder why we see differences in body mass index and other problems for people of color. Detroit, for example, is an important example of a city that for many years did not have a single major grocery store within the city limits in the 1990s, not one. And this is created, of course, by market forces. None of these grocery stores or grocery chains are saying we deliberately want to harm the health of people of color. Rather, they are looking to site their stores where they can make the largest profit. And when neighborhoods suffer from disinvestment going back generations, those are the neighborhoods, of course, where grocery store chains do not want to site their stores. There's more. Black and Latino neighborhoods have fewer parks and green spaces than white neighborhoods, fewer safe spaces to walk, jog, bike, or play, fewer gyms, fewer recreational facilities and swimming pools. So we've done a lot of work in the United States to wag our finger at people and say, you need to eat better, you need to exercise more, but you need to consider the context in which people live. Neighborhood context can either facilitate those healthy behaviors or discourage them. And too often in highly segregated communities of color, the characteristics of those neighborhoods discourage healthy behaviors. We know that low-income communities and communities of color are more likely to be exposed to environmental health risks. In 2004, a study found that 56% of residents in neighborhoods with commercial hazardous waste facilities were people of color, even though at that time they only comprise about 30% of the US population. So people of color are disproportionately in neighborhoods that are overrun with polluting industries and other environmental health risks. Why is that? Because those are the neighborhoods that often lack the political power to resist the siting of those kinds of industries in or near their neighborhoods. Wealthier, whiter neighborhoods have the political power and connections to be able to resist those kinds of health risks. And then we have the poverty tax. People in poor communities have to pay more for the exact same consumer products than those in higher income neighborhoods. So you pay more for auto loans, you pay more for furniture, appliances, you pay more for bank fees. And that's if you can find a bank. Many highly segregated, high poverty communities of color do not have bank branches, literally unbanked. And you can imagine the consequences of that spatial separation on the ability of individuals and families to save money, to even have a checking account. So these are the many structural barriers that we see, characteristics of communities that very much fall along racial lines. Now, of course, the issue here is not so much about whether or not people of color live next to each other, but rather neighborhood poverty concentration. By enforcing racial residential segregation, our governments, our private sector, our civic sector, all contributed to concentrating poverty in neighborhoods in ways that would end up disadvantaging everybody in those neighborhoods. We know that when we look across all of our metropolitan areas in the United States, that whites are much more likely than people of color to be found in low poverty census tracts, low poverty neighborhoods, as this slide shows you. If you look at the bar on the far left, as you can see, it suggests that about 90% of white Americans live in low to moderate census tracts. That's indicated by the green shading in that bar. That means that 90% of white Americans in metropolitan areas live in the kinds of neighborhoods that promote good health, that have good schools, that have businesses, jobs, that are economically vibrant and that are often free from environmental health risks or have reduced environmental health risks. As you can see from the second bar from the left, for African Americans, only about 55% of African Americans live in low poverty census tracts. And similarly for Asian Americans, American Indians, and the Latinx population, these populations are all disproportionately found in medium and high poverty census tracts. Medium poverty tracts are those where between 20 and 30% of the residents live below the poverty line. And high poverty tracts are those where 30% or more of the residents live below the poverty line. Now, you might say, isn't that to be expected given differences in education, income, and wealth across different racial and ethnic groups? Well, we can control for differences in income by looking at the share of poor, white, African American, and Latinx families living in different kinds of census tracts. As you can see from the set of bars on the far left, poor white Americans are much more likely to be found in low poverty census tracts than similarly poor Latinx or African American families. In fact, about 70% of poor white families, as you can see from this graph, live in low poverty tracts, whereas only about a third of poor African Americans and 40% of poor Latinx families are in low to moderate poverty tracts. In contrast, Black and Latinx families, poor Black and Latinx families are much more likely to be found in medium and high poverty census tracts than similarly poor whites. As you can see from this slide, about 40% of poor African Americans are in high poverty tracts, whereas white families are much less likely to be found in those kinds of census tracts. Let me provide an example from right there in Ohio, metropolitan Cleveland, where there are vast differences in the level of poverty concentration for children of different racial and ethnic groups. And I know many of you are familiar with the Cleveland metro area, so I don't need to offer this data to you for you to understand that there are vast differences in the types of neighborhoods that kids of color live in relative to white children. But if you look at the set of bars on the far left, what this shows is that over 90% of white children in metro Cleveland live in low poverty census tracts, those between 0 and 20% poverty concentration. A little over 90% of Asian American and Pacific Islander American children in the Cleveland metro area live in low poverty tracts. About 80% of the Latinx youth in Cleveland live in low poverty tracts, but only about 37% of African American kids in the Cleveland metro area live in low poverty tracts. Those Black and brown kids are much more likely to be found in medium, high, and extreme poverty census tracts. That is, those tracts where 40% or more of the population lives below the poverty line. Now, again, you might say, isn't that simply the result of differences in income, education, wealth? Well, let's again control for income by looking only at poor families in metro Cleveland. The set of bars on the far left shows a similar pattern to what I just explained. Poor white children in metro Cleveland are much more likely to live in low poverty tracts. Over 70% of poor white children in metro Cleveland are in low poverty tracts, whereas fewer than 1 in 5 poor African American kids is in a low poverty tract in the metro Cleveland area, and about 28% of poor Latinx kids are in those tracts. Those Black and brown kids are much more likely to be found in medium, high, and extreme poverty tracts than similarly poor white children. How does this happen? Again, look to our history, because those white families had the freedom to choose among many different neighborhoods, had much more choice than Black and brown families in the Cleveland metro area. And I'm picking on Cleveland here, but this is true of every metropolitan area in the United States. We see similar patterns as what we see in Cleveland here. So the point here is that poor white children, despite the disadvantage of being poor, are much more likely to be in neighborhoods that are conducive to good health, to educational opportunities, to employment opportunities, economic opportunities for their parents. This is a form of structural racism that our country has never come to grips with. I want to point to a report that I did with my former organization, the National Collaborative for Health Equity, with the Cuyahoga County Place Matters team. The Cuyahoga County Place Matters team was part of our network of Place Matters teams around the country who were attempting to illustrate how place matters for health. They were able to document the heavy concentration of health risks in communities of color as a result of residential segregation and the relative lack of access to health enhancing resources for this population relative to white residents in the Cleveland metro area. And what you see here is an example of the kind of federal home ownership loan corporation map that I was referring to earlier, these notorious redlining maps. And of course, those of you who know the city of Cleveland know exactly where these neighborhoods that are redlined are in that city. Many of these neighborhoods remain deeply poor neighborhoods as a result of systemic disinvestment in those neighborhoods brought about by government policy and action. So I've talked quite a bit about the problem. How do we solve these problems? We know that there are several themes that emerge from our scientific literature. We know first that we need to focus on prevention, particularly the conditions in which people live, work, play, and study. Here in the United States, we invest far more in health care than prevention of health problems. For every federal dollar that we spend on health and health care, we spend about 5 cents on prevention. We need to better balance that and invest in prevention. I'm going to describe some of the kinds of things that we can do to ensure that conditions for health are much better and richer, particularly in those communities that have suffered from disinvestment for many generations. Second, we need multiple strategies across sectors. As I hope my talk has illustrated, these are not just problems for our healthcare systems or for public health. They necessarily involve many agencies of government, housing, education, transportation, the environment, and we need to be linking across public and private sectors to help solve this problem, because too often the private sector has been part of the problem through things like citing polluting industries in communities of color, failing to cite health enhancing resources like grocery stores or supermarkets in these communities. Finally, we need a sustained investment in a long-term policy agenda. It took us hundreds of years to get here. We're not going to solve these problems in 2 years or 4 years or by the next election cycle. We have to be serious about investing across generations to undo what we have created and to ensure that every child has an equitable opportunity for good health. There are two general buckets of policy strategies that my colleagues and I have promoted. One are place-based investments, investing in communities to reduce the concentration of health risks and to bring in health-enhancing resources to communities that too often are lacking. And I'll describe some examples of this shortly. The second bucket of strategies are people-based investments, investing in things that we know work to help promote good health. Things like early childhood educational interventions. We know from a plethora of studies, longitudinal studies, and in many cases, randomized controlled trials where children are randomly assigned to experimental groups or control groups. And those early studies suggested long-term benefits of high-quality early childhood educational programs, similar to high-quality Head Start programs. We know, for example, from the ABC-Darian study, that children who received high-quality early educational interventions when they were 3, 4, 5 years old had much better outcomes as adults than children in the control group that received no early educational interventions. These young people are more likely to have better occupational histories, better educational attainment, etc. So there is something about investing in early childhood education that can help to mitigate the risks that children face, particularly if they're living in a high poverty neighborhood or if their families are living below the poverty line. Increasing housing mobility options is also a people-based strategy that I'm going to talk a fair amount about, because my position is that if we know that government helped to create the conditions that bring about and sustain residential segregation, I believe government has a responsibility to undo that original injury and ensure that families have true choice as to where they may settle and live. So let's talk first about place-based interventions. What can we do to reduce the concentration of health risks and bring in health-enhancing resources? Well, fortunately, there are communities around the country that are experimenting with novel policy strategies that we know are beginning to work to turn the tide for these neighborhoods. We know we can improve food and nutritional options through incentives for farmers markets and grocery stores, and to regulate fast food and liquor stores. So let me reference Detroit again. I mentioned that Detroit in the 1990s, for a considerable period, had no grocery stores within the city limits. Now there are dozens through things like local and state policies that help incentivize grocery stores to come into so-called food deserts. The Commonwealth of Pennsylvania started the so-called Fresh Food Financing Initiative back some years ago. It proved so successful in incentivizing grocery stores to come into food deserts and set up shop that the Obama administration some years ago established the federal Fresh Food Financing Initiative, providing financial incentives, tax benefits, land use and zoning benefits to help attract grocery stores to come into these neighborhoods. Many of these grocery stores found that they achieved a so-called win-win-win. Not only were those grocery stores able to turn a profit with those financial incentives, but they were also a good source of jobs in the neighborhood, in addition to providing healthy food retail. We can also do things like structuring land use and zoning policy to reduce the concentration of health risks, ensuring, for example, that we don't allow neighborhoods to become overrun with vendors selling unhealthy food products, such as fast food outlets, corner stores, etc. We need to balance those stores with vendors selling healthier food options. Many communities are also beginning to look at policy tools like health impact assessments to determine the public health consequences of new policies such as housing, transportation, labor, education policies. Policies made in those sectors often have health consequences, as I hope I've suggested this afternoon. So policymakers need to understand what the potential consequences, positive or negative, of what those policies might be for the health and well-being of their residents. We can also improve the physical environment of communities. We can do things like improving air quality. One of the best examples of this that I'm aware of comes from New York City, where advocates began to document a heavy concentration of asthma and respiratory disease among children living in West Harlem and other neighborhoods. Those cases of asthma tended to be concentrated around bus depots owned by the city. So when bus drivers would come to the depot in the morning, they would turn on the ignition in their bus, let the bus warm up. But of course, that allows a lot of diesel exhaust and particulate matter to concentrate in the air around those bus depots. Those advocates were able to work with the city to disperse those bus depots and to employ greener practices so that we wouldn't see heavy concentrations of diesel exhaust in neighborhoods, particularly those where there are children living nearby. We can also do things like expanding the availability of open space and exercise and pedestrian-friendly communities. This is happening in communities around the country, taking former industrial waste sites and making them safe again for living, play, and development. Now let me turn to another people-based strategy, and this is around the issue of housing choice and mobility that I referenced earlier. Again, my position is that if government created residential segregation and has helped to maintain residential segregation, we need to be thinking seriously about interventions to reduce the negative consequences, such as heavy levels of poverty concentration. So this leads to a very important study that was conducted in the beginning in the mid-1990s all the way through 2005. It was the Moving to Opportunity study supported by the Department of Housing and Urban Development. Moving to Opportunity was a 10-year randomized controlled trial to test the effects of moving from high poverty to low poverty neighborhoods among low-income families. We know that this can be done because there are many families who need tenant-based rental assistance, things like Section 8 housing vouchers, to supplement their own income so that they can afford rental properties. Today, most Section 8 housing voucher holders are in high poverty neighborhoods for many reasons, including the fact that there are many landlords who won't accept Section 8 housing vouchers, or these families are simply not aware of opportunities to find housing in lower poverty neighborhoods. So many households receiving Section 8 vouchers today are confronted by an array of barriers, market conditions, discrimination, a lack of information, a lack of transportation, among many other factors that leads them to remain in high poverty neighborhoods. So the Moving to Opportunity study was possible because so many thousands of families around the country are on waiting lists to receive those housing vouchers so that they can supplement their own income and afford better rental housing. So MTO began in the 1990s with nearly 5,000 low-income families with children who were in high poverty public housing projects. Families who volunteered to participate in this study were randomly assigned to one of three groups. One was an experimental group that received housing vouchers that could be used only in low poverty areas, as well as counseling and assistance to help them find housing in low poverty neighborhoods. A second group received vouchers that could be used anywhere, but no counseling or assistance. And a third control group did not receive housing assistance vouchers, but remained eligible for other forms of public assistance that they otherwise would have been entitled to. Moving to Opportunity was conducted in 5 cities, Baltimore, Boston, Chicago, Los Angeles, and New York City. What investigators found after 10 years was that parents and families who moved to low poverty areas had lower rates of obesity and depression and reported lower levels of stress. Living in a lower poverty neighborhood was significantly associated with improved college attendance for children and higher earnings for children who were young when their families moved. Those children who moved to low poverty neighborhoods also were less likely to become single parents as adults. These treatment effects were pretty substantial. Those families that moved from high poverty to low poverty neighborhoods had about 31% higher income than people in the control group. In contrast, however, those same moves were found to have negative long-term impacts on children who were older than 13 when their families moved. So we need to be clear that this is not a panacea and it is not an option for every family. It could be that those older children experienced significant disruption, a loss of social ties that may have impeded the benefits of moving from high to low poverty neighborhoods. So some important considerations from the Moving to Opportunity study. As I said, housing mobility is not a panacea. Comprehensive strategies are needed to reduce stressful conditions in high poverty neighborhoods. We also know that wholesale dislocation is not effective. Sadly, we know from our history that too often communities of color and low-income communities have been forcibly removed with harmful consequences, things like so-called urban renewal, transportation projects that often deliberately bisected communities or separated communities of color from white neighborhoods. That kind of displacement can have significant effects, negative effects on those residents because of the disruption of social ties. It eroded social cohesion and the solid ties that neighbors had. So people-based interventions such as housing mobility should always be accompanied, in my view, by place-based investments to stimulate economic activity and improve community conditions in under-resourced communities. So having simply place-based interventions to improve conditions for health alone is not sufficient. Having only people-based investments is not sufficient. Both need to happen simultaneously. And let me illustrate, let me give you an example of why this is important. Too often in our metropolitan areas around the country, when we make place-based investments to enhance economic activity, to bring in more amenities, to bring in more attractive shops, stores, housing, et cetera, too often, if that is happening in a high poverty, segregated community, what's the consequence? Those families that have been there often for generations are forced out. We see this happening in community after community. And so that kind of displacement as a result of place-based investments is certainly something that we need to be very careful about. And it is another reason why I'm an advocate for the use of housing vouchers, housing assistance, to help families to stay in those neighborhoods that are undergoing renewal and revitalization. Why not let those families that have been in those neighborhoods, sometimes for generations, to have an opportunity to stay and reap the benefits of the investments that are being made in those communities? I'm obviously talking about gentrification, and there are ways that we can combat gentrification through smart housing policies that can help residents of those neighborhoods stay where those neighborhoods are improving. I'm going to wrap up my talk shortly, but I want to provide just a few more examples of the importance of place and race for health. This is a map, one of the many maps that we constructed through Place Matters, our initiative, where we looked at the distribution of people in a defined geographic space. Here we're looking at Bernalillo County in New Mexico. This is Albuquerque, New Mexico's largest and most populous county and city. This is a dot density map where each dot represents 25 people. The blue dots represent where white residents of this county live. The purple dots represent where African-American residents of this county live. The orange dots represent where Latinx residents of this county live. You don't need to be a demographer to see that Bernalillo County is highly segregated, with white residents concentrated in the east and the north, the Latinx population concentrated in the south and west, and African-Americans similarly living in those neighborhoods. Keep this in mind as you look at this next map, which shows the distribution of life expectancy in Bernalillo County by various census tracts in the county. Those census tracts that are shaded in the pale yellow have the highest life expectancy in Bernalillo County. Those shaded in the orange or rust color have the lowest life expectancy in Bernalillo County. There's one census tract in Bernalillo County where people on average can expect to live to be about 66 years of age. That's comparable to some developing countries. In contrast, there are some census tracts in Bernalillo County where people can expect to live to be on average 94 years of age. That's a 28-year difference in life expectancy, and some of these census tracts are just a few miles apart. Let me provide another example of this kind of relationship, and this will be from the city of New Orleans. Many of you are familiar with New Orleans. Again, we're looking at a dot density map where the blue dots represent where white residents live. The purple represents where African-American residents live, orange, the Latinx population. And again, you can see that New Orleans is a highly segregated city, with African-Americans in particular concentrated in the east and southeastern portions of New Orleans, and whites concentrated in the south and northwestern portions of the city. Again, keep this distribution of the population in mind as you look at this map of life expectancy across different zip codes in the city of New Orleans. As you can see, again, the color code here is that the light yellow, pale yellow, represents the highest life expectancy. The orange or rust color represents the lowest life expectancy. There's one zip code in New Orleans where people can live to be, on average, 55 years of age, a pretty remarkable statistic here in the United States. In contrast, if you drive up the freeway to Lakeshore, Lake Vista, their residents can expect to live to be about 80 years of age. That's a 25-year gap across these different zip codes. And this is why we say that when it comes to your health, often your zip code is much more important than your genetic code. All right, I'd like to conclude with a quote that I like from Dr. Mary Bassett, former Commissioner of Health in New York City. She wrote that anti-racism is a collective healing without which our nation will remain painfully and inequitably divided, corroding opportunity, spirits, and bodies alike. So even though Dr. Bassett is a physician and epidemiologist, she's drawing a straight line between racism and health in the United States. I hope this talk has been helpful to illustrate the many ways in which racism is eroding the health of people of color and what we can do to stop it. It's been a pleasure to talk with you today. I look forward to your questions and comments.
Thank you. Thank you very, very much. And let me just say before we start the question and answer that John and I had a private conversation, very brief one, during the lecture to try to determine whether just to open the floor directly to individuals in the audience and let them ask their own questions rather than go to the chat room. And listen, then there's, I don't see any questions in the chat room yet. So I'm, you know, I'll just start with the question and we'll see how it goes. You know, we'll see how it goes. Well, I want to start with an observation first and then ask a question. But a couple of things that that you mentioned reminded me of some things that are happening right now, right in this instant. That in case there are people in the audience who are interested, you know, they could look into. One has to do with, and I'm going to sort of contextualize this, but very briefly. That, you know, recently the Black Lives Matter movement actually, you know, cited policing itself as a public health issue. So I just wanted to tell people, in case you haven't seen it and you're interested in looking for it, I think, I don't know if it was just the announcement today or if starting today in the state of Virginia. And Dr. Smedley, you might be able to tell us more about this, I don't know. Beginning today, I think it's beginning today, police can no longer stop drivers for minor traffic offenses. It's now against the law starting today, and I thought that was just a wonderful thing. And let's see, there was one other thing that was related to it, but I've scribbled a lot of notes and I can't see where I wrote it, so I'll have to come back to it. So anyway, let me just ask a question. Well, one of them has to do, one question that I have has to do with President Biden's Build Back Better program, and the real, apparently serious difficulties that Congress is in right now, you know, getting funding for this effort. And I was just wondering, you know, because you're close to Washington, because people in Congress know you, maybe you have lunch or dinner with them every once in a while or something. You know, I was just wondering if you know, if you can tell us anything about parts of that program that address exactly the kinds of things that you talked about. You know, we've known for a long time, I'm almost positive of this, I'm like 98% positive of this, that the Head Start program was the most successful program of the whole war on poverty. I'm almost absolutely positive on that. And I know there are provisions in that budget that have to do with pre-K schooling and care and all of that. So I'm just wondering if you know anything about the proposals and the extent to which any of them might address some of these issues that you're talking about, not just regarding children and childcare, but housing and, you know, and markets and, you know, everything. Go ahead.
Absolutely. That's a very important observation, Professor Shaw. And you're right. The Biden administration's effort to address racial inequality is perhaps the most comprehensive approach to seriously tackling racial inequality across a range of issues: health, wealth, education, economic opportunities, employment opportunities. In many respects, it's quite stunning, and it shows you the maturity of the scholarship in this area. The scholarship in this area strongly suggests that taking a comprehensive approach like what I'm suggesting here, holistically addressing education, housing, transportation, jobs, all of these are necessary to reduce hundreds of years of policymaking that has either been purposefully enacted to create racial inequality and perpetuate racial inequality, or that has had, to be charitable, unintended consequences to create racial inequality. And it was only in this administration that this was possible. Recall, many of us were very excited when the Obama administration came into office, but President Obama was very clear that he could not have an agenda as progressive as President Biden because he did not want to be perceived as being the first African-American president who focuses his efforts on helping Black people. Now, I'm not suggesting that the Obama administration did nothing to help Black people. The Obama administration was the first administration to put in place a very important housing policy called Affirmatively Furthering Fair Housing, a policy which the administration that followed the Obama administration attempted to erase. Well, President Biden is looking to bring that back. Affirmatively Furthering Fair Housing simply is a federal effort to incentivize local jurisdictions to examine patterns of residential segregation and to work in partnership with community residents to figure out how to undo concentrated poverty and entrenched patterns of segregation through things like housing policies that purposefully create mixed income housing in neighborhoods where it's desperately needed. Encouraging policies around multifamily housing to encourage more affordable housing in neighborhoods that have been previously off limits financially to lower income families, and using housing vouchers to help promote true housing choice. So it has been really exciting to see this agenda, one that the Obama administration could not have done politically because it's too bold, too audacious around tackling the roots of racial inequality. And that, I'd submit, is why we're seeing so much resistance in Congress to this administration's agenda, because it is intentional about undoing policies and practices that have perpetuated racial inequality over many generations.
I'd like to just follow up if I could. If you were in a position to advise all parties, Biden and Schumer in particular, and Pelosi, you're in a better position than we are. Would you advise a kind of a shotgun approach to this, to the Build Back Better? In other words, just fund everything for a short amount of time and push it through, or go selective and fully fund certain programs?
Oh, that's a great question, Professor Brooke. Thank you for that. As I suggested in this talk, I firmly believe that we need comprehensive approaches and sustained investment in those approaches. We have learned from painful experience that nibbling around the edges to promote racial equality doesn't work. We have had a fraught time, for example, in this country, attempting to desegregate our schools. Looking back at the 1954 Brown versus Board of Education decision, all of us know, particularly you historians know, about the massive political resistance to the Brown v. Board decision. And unless we are prepared to push and insist that we find ways to tackle school segregation and residential segregation. School segregation is a deep challenge in this country. We know that kids of color are increasingly segregated in high poverty schools over the past 20, 30 years. These are children who have less access to advanced placement coursework, less access to teachers who are highly credentialed in the subjects that they're teaching, less access to the best educational technology, teaching tools, facilities, et cetera. So I just offer that as an example to say that half-hearted approaches, approaches that don't take a comprehensive view and understand that we need a full investment to tackle some of these problems, will always fall short. And so that may be politically naive, but I do believe that shotgun approaches, unfortunately, are not going to realize the benefit as more comprehensive approaches that are supported over time, significant time, with significant resources to ensure that we undo what we have created over many hundreds of years.
Right. Well, my thinking was that put it all on the table for 2 years, rather than some of it on the table for 10 years. But you know, that's an interesting angle. Yeah. Sean, why don't you just open up and ask your question?
Let me just make sure first that if there's anyone in the audience who wants to say something or
Well,
wants to ask a
Sean
question.
Yeager has a question.
Oh, you said Sean. I thought you said Shaw. I'm sorry. Go ahead.
No.
Hello, Dr. Smedley. Thank you so much for this talk. I have a question about what exactly you mean by health. And for some context on that, I'm rooted in disability studies. I myself am autistic. A lot of times health is framed as, the elimination of disability, the cure of autism, which is really just eugenics. I don't mean at all to imply that that's what you're advocating for. Within a disability framework, health becomes a fraught notion. And then, of course, within a neurodiversity itself, it's a very racialized issue where like Black and brown autistic kids, instead of getting diagnosed as autistic, they'll be said to have behavioral problems and things like this. So I'm just wondering if you could dive into these issues a little bit.
I so appreciate that question, Sean, because you are spot on. In my view, we have a number of isms that we have to tackle. Racism is one. We have a society that is ableist, not accepting the incredible rich diversity of abilities that people bring to the table. And you are right that we have taken the weapon of ableism and we've racialized it in ways that significantly disadvantage kids of color, but it also hurts the whole society because we are not recognizing the tremendous value that all segments of society bring, regardless of ability status. It's so interesting because racism, of course, is foundational to this country, but we're not going to achieve health equity without tackling ableism, ageism, heterosexism, sexism, all of the various destructive social hierarchies that result in inequitable opportunity, which in turn results in inequitable health, mental health, spiritual and physical health. So I so appreciate your question because this is an area that, in my view, has been relatively understudied. We certainly know that kids of color have been disproportionately shunted off into special education. We use assessment tools that have been normed with white children, white populations, and we've got to understand how ableism undercuts all of that. That is the reason why we do that. And so we have to learn to value what everybody brings to the table and support individuals to achieve their highest health, educational, and occupational status. And all of those isms are barriers to the achievement of that goal. I'm convinced that we will always, all of us will suffer as we allow these isms to persist in our society because of the waste of human resources and talent, as the definition from Dr. Kamara Jones suggests. So I sure appreciate that question, Sean. I applaud you, and you're making me want to dive more deeply into this literature to understand the connections between racism, ableism, and other destructive social hierarchies that, again, are ultimately hurting all of us.
Thank you very much. If you're looking for a place to start, I highly recommend All the Weight of Our Dreams on Living Racialized Autism. Excellent text.
Oh, wonderful. Yes. Can you say the title again?
All the Weight of Our Dreams. I'll drop a link in chat.
Okay. Thank you so much.
No problem.
Okay, since no one has a hand up, let's see. Oh no, somebody does have a question. I see. Go ahead. Yes, go ahead.
What are the fallacies in the separate but equal paradigm?
Would you repeat that, please?
What are the fallacies in the separate but equal paradigm?
Because separate always means unequal in this country, whether it's our educational system, our healthcare system. There's another talk I do on this phenomenon of medical apartheid in our healthcare systems. People of color are largely seen in separate and unequal healthcare systems relative to white patients. This is, in my view, one of the biggest reasons why we see a healthcare quality gap. We not only have a healthcare access gap in that, healthcare is a market commodity here in the US. So if you don't have health insurance, you're not likely to get good healthcare. But that problem is compounded by the fact that when African Americans, Latinx populations, indigenous folk get healthcare, the healthcare that they're receiving is often in clinics, hospitals, settings that have lower quality scores relative to the places where more advantaged people go for their care. So I have yet to see an example in the US of an instance where separate is truly equal. And then even if it was, you'd argue, what's the damage to society when we remain separate? I think our separation has contributed to much of the social division that we see today, the lack of understanding that we have of each other, and the perpetuation of an othering because people simply do not know each other across racial and ethnic lines. So that's my view on separate and unequal. Separate is always unequal.
Thank you.
Thank you.
Okay, I'm going to ask a question about COVID. I'm not even sure how to ask the question. I'm not sure quite what it is. It's here. It might actually be here to stay. I don't think we truly know yet, in one form or another, hopefully in a much less dangerous or deadly form than it exists now. But if it's going to be here forever. But I'm just wondering if you have any, we know that in terms of infection rates, in terms of hospitalization rates, or maybe not in terms of hospitalization, but in terms of death rates, that it has disproportionately affected poor and people of color. And I don't know, what that statistic looks like now. It's so interesting. One of the really interesting things to me about this is normally I'm guessing that when we talk about disease and trajectories, we're looking at, over spans of decades, maybe even centuries. And this is something that's been with us for a year and a half. And we already have pretty clearly marked patterns. I'm wondering if the patterns are still the same, or if they have shifted. I'm wondering if you can offer any comments about resistance, particularly among Black folk, but people of color in general. And I'll say in terms of Black folk, offer any ideas about why there's such resistance there beyond the medical experimentation that we know has gone on. Is there something else that's functioning out there? And I know that's putting you on the spot. I know that, that's asking you to, look into some kind of crystal ball or something. I don't know. But I just want to know what you're thinking about COVID right now, and, and its impact, and what can we do? What can we say to people? I don't know. What, like I said, I don't know quite what the question is, but I did want to talk at least a little about COVID.
Oh, sure. And this has been something that all of us have been thinking about. So I sure appreciate that question. So COVID obviously has revealed the inequality that is at the foundation of our country. And we saw that in terms of who was most at risk for infection, who was most at risk for serious illness, hospitalization, death. Early on, people of color were particularly at risk. Many tribes were just devastated by the impact of the virus. People of color, disproportionately frontline workers, so-called essential workers, and in jobs too often where they were not provided with the kind of protective equipment that would keep them safe as they interact with the public. So we have racial inequality that's again magnified. Now we have other phenomena emerging where we see resistance is as much along political lines as it is along racial and ethnic lines, right? And so the bottom line for me is this. There are those who like to proclaim that the United States is number one in terms of our healthcare system, number one on so many dimensions. We have about 6% of the globe's population, but at one point during the pandemic, we had 25% of the world's mortality. Now, if we have the world's best healthcare system, how does that happen? It happens because of the underlying inequality in our society. Societies that have higher levels of social cohesion, more cooperation, less division, did better during the pandemic than societies characterized by division. That's a lesson that we haven't learned. And so despite the fact that there's one thing that we are number one on when it comes to healthcare, and that's spending, not outcomes. And we have continued to spend trillions upon trillions of dollars, failing to recognize that, yes, medicine is important. Yes, vaccinations are important. But underlying COVID is the distrust, the division along racial lines, political lines, geographic lines. It is fascinating to see the states that have been resistant to mandating good public health behavior, mask wearing, hand washing, receiving the vaccine. It is so clear when you look at a map of the United States and where we have case rates, that politics is now the underlying fault line for COVID. So we've got to decide, either we come together and recognize that our fates are intertwined. It is that intertwined destiny that Dr. King talked about that is keeping us from recovering from this virus. And I'm going to predict that if we continue to be divided politically, if we continue to allow inequality to fester, if we continue to allow racism to infect our communities at all levels, the virus will stay with us. And that's what we haven't learned, that there's so much about our social and political arrangement that dictates the course of the virus, not just who gets vaccinated and who practices good health behaviors. So I so appreciate the question, because for me, what it points to is the fact that if we continue to remain divided, we're going to take years to fully eliminate this virus.
Yep.
Thank you. I think that you're being optimistic. I pray that
I actually didn't hear any optimism there. I hate to say it.
I pray that you're not. But I think that, just looking at, the way the way that things look around me, I have doubts that it'll be around just for years. I really do. Yeah. But you touched on something. If there's no other hand up or question in the chat, you touched on something that I would love to say more about. Again, I should have warned everybody. I'm from the South. I often start talking before I know what I'm going to say. I can ramble a lot, and hopefully I'll get to a point, an appropriate point. But you talked about something that's been on my mind for a long time, and I've been trying to figure out how to write about it. In some ways it's such a big issue. In other ways, it's too big. And I don't know what the problem is, but anyway, this whole notion about the importance of understanding that we all are going to have to get there together. Wherever there is, we're going to have to get there together, And I think about Southern history. I'm a social historian. I look at, poor people, minorities, women, immigrants, Black people, working class people, those are the things that are closest to my heart. And maybe I'm a closet labor historian, or maybe I was a labor historian in a past life, but I'm interested in how ordinary people live in the world. and lived in the world historically, regular people. And one thing that impresses me about the South is that politicians, I guess, I don't know who, but a lot of people have spent a lot of time and a lot of money making sure that certain people don't get ahead. And the consequence of that has been that almost nobody then can get ahead. I mean, there's a handful of the same handful of people at the very top who continue to, it's just like COVID. And COVID, 1% of people, increased their wealth by billions and billions of dollars, and everybody else lost money. Whether it was just whether it was in income or whether it was in healthcare costs or whatever. But anyway, and it just, I look at the South. I love the South. I'm going back, as soon as I can, I'm going back. I'm going back there to live. But I don't understand how it is, that this is a place where this, as a region generally, education levels are the worst, healthcare levels are the worst, mortality rates are the highest, wages are the lowest, everything, every little metric that you can tick, they're horrible there, and people work hard to keep it that way. And people who need that to change somehow have many of them have become co-opted, and they don't want unions anymore either. It's just bizarre to me. And it relates to this COVID stuff too. I mean, people are saying things and doing things that reflect what I would think is just no common sense whatsoever. Supporting projects and ideas that are not in their best interest, that kind of thing. And so I'm just wondering, like, what can we do? How can we get people to both think for themselves and recognize, look at policies and programs carefully enough to realize how those very policies and programs are inhibiting your advancement? And I'm not just talking about Black people. I mean, I'm talking about a bunch of different groups of people who are Southerners now, and by the way, the South is becoming the most diverse part of the country right now. I mean, it probably already is. I mean, but immigration into the South has dramatically transformed what the South looks like now, but the South still behaves the same in some ways. Sorry, I'm sorry for just rambling in that, but I hope you can figure out anything out of that to address.
I think you said it, Professor Shaw. People have tried so hard, and this is not just in the South, of course, but people have tried so hard to keep some people down that they're keeping everybody down. And you see that reflected in this kind of statistics you're talking about. So again, will we realize our fates are intertwined and that we hurt all of our society when we don't extend all of the opportunity that we can, particularly to those who need opportunity? And I think you exactly put your finger on what the problem is, that we're so determined to keep some down that we want to keep almost all of us down.
Thank you.
Yeah.
I appreciate, just your the way you made me not look quite as stupid as I felt trying to ask that question.
I think that was a great observation.
I felt like I'm losing it here. I'm losing it here.
Well, and of course, the other side of that is, what is this? I mean, we can have a very simple explanation of what, certain people in the South are working to keep other people down. Well, how does it work north of the Mason-Dixon line? In other words, what are the groups? What is the power structure? It's not precisely the same thing, but it is something. And exactly how that, that's a larger, I mean, as large a problem as because clearly, you look at those. I counted the number of Midwestern cities that had the worst segregation in the country. Say nothing of New York and Newark. I wondered where Boston was in that. Philadelphia is not too far behind either, but I guess South Philly is fairly integrated. Sean has just suggested that oppression is just too profitable, which may in fact be the the answer to our story.
That's an incredible, that's a,
Yeah.
it seems so obvious, but just looking at it and thinking about it, it's just breathtakingly stunning, that the idea of it, but it's probably exactly true, correct.
I agree with Sean.
Well, it is now 6:05, so we have, we probably should bring our, unless there's any last question out there, or getting comments about voter suppression and gerrymandering. I would say that's happening in the state of Ohio too, not just in the South, but certainly in the historically South as well. My worry is the patterns of the historical South are infiltrating and have been infiltrating for decades the historical North. Brian, would you like to say a last word, or shall we ring the bell?
I just want to say how much I've enjoyed this conversation. And one of the things that I enjoy most is learning new things. I've learned so much from this conversation. Great discussion, great observations. And I appreciate the observations that you both have made, Professor Sean Brook. And Sean, I'm going to look up that book. Thank you all for participating in this. Thank you for caring about this issue. I've really enjoyed this. Thank you.
Thank you so much for being here. We appreciate your time and treasure your knowledge and your experience. Thank you.
All right.
You all have a good day, the rest of you. Stay safe this weekend.